Today, this is our monthly event. I have Dr. Ripu Hundal, Caroline Weber, and Donna Gunkel with me. We are going to cover gestational diabetes, and we'll be looking at it from the endocrinologist standpoint and also from the nutritionist standpoint. And that is our topic today. So I'll go ahead and start sharing my presentation. So as most of our patients already know, our Wednesday Wellness webinar, second Wednesday of the month, we do the actual presentation. And then the fourth Wednesday, we have the support group. And other than myself, Donna Gunkel as the Clinical Integration Director, Dr. Hundal is our Program Director, Caroline Weber is our Head Dietitian, and we have two social workers, Roxana and Carla, who are working with us and with our patients. So we are gonna go ahead and start with our topic. Dr. Hundal, how are you doing?
Oh, good, thank you. Good evening.
The topic is gestational diabetes, so we are with you now.
All right, great, thank you. All right, so today's an interesting topic, gestational diabetes. This is defined as a type of diabetes that is first diagnosed or starts during the pregnancy. So some people may have undiagnosed diabetes. They haven't been to a physician. That woman gets pregnant and then gets diagnosed with diabetes during her pregnancy. This will be still considered as gestational diabetes. So that's important. Then later on after delivery, then we try to figure out whether the patient had pre-existing diabetes or not. So anything first diagnosis during pregnancy is considered gestational diabetes. So roughly the incidence is any 2 to 10% of all pregnancies in US are affected by gestational diabetes. So where the abbreviation you see GDM, that is gestational diabetes. 80% of the people with diabetes complicating pregnancy have GDM. So majority of them present during pregnancies. Only 10 to 20% happens in people who have pre-existing diabetes. Next slide. So what determines that one person is at higher risk for developing gestational diabetes during their pregnancy? So if somebody has prior history of gestational diabetes, yes, the subsequent pregnancies also increases their risk. If somebody has a history of a birth of a baby which is more than 9 pounds or more, that should raise alarm that maybe person had gestational diabetes during the previous pregnancy. Anybody who is overweight, obese, they are at higher risk. With more than 25 years of age, as women age, they become more insulin resistant, and gestational diabetes is considered an insulin resistant state. So they are more prone to develop glucose intolerance during the pregnancy. Family history is important, more genetics, that increases the risk. Previously, we covered a topic with polycystic ovary syndrome. So that is also an insulin resistant state, and those females with PCOS, once they get pregnant, they have a higher risk of developing gestational diabetes. Then, but the certain ethnic groups, African Americans, Hispanics, Latinos, American Indian, Alaskan Native, then Native of Hawaii or Pacific Islander, these individuals are at higher risk for developing gestational diabetes because in general, they have a higher risk of developing diabetes because of the insulin resistant state. So these type of factors we should keep in mind. And as a patient or a person who is listening to these talks, they should look into these things. And if they have belong to any of these categories, they can also be proactive and talk to their OBGYN and say, okay, I am at risk for gestational diabetes. What should I do? How can I lower my risk? or how should I be screened? The reason being, most of these patients with GDM, they have no symptoms. So it's not like you wait for the symptoms and then say, oh yeah, I have gestational diabetes. Majority of them will have no symptoms. Only in people who have uncontrolled diabetes, or undiagnosed diabetics, their blood sugars are running very high, and typically, as someone else, non-pregnant female, will have symptoms of increased urination, increased thirst, weight loss. So they can present like that. But majority of people, women with gestational diabetes, will have no symptoms. So how do we, next slide, screen them? So typically screening is done between 24 and 28 weeks of pregnancy. Usually the insulin resistance worsens during the second and the third trimester of pregnancy. So that's the time when they screen. If someone has prior history of gestational diabetes or risk factors, which I explained earlier, then they can be tested earlier. If they pass the screening test, then we can wait and then again screen them periodically just to make sure we don't miss the diagnosis of gestational diabetes. If someone presents early in the pregnancy with a very high blood sugars, then we start concerned about, like, okay, maybe this person has undiagnosed type 1 or type 2 diabetes. You check their A1C, look at the previous glycemic control, because these are the individuals which will have, if they get pregnant with uncontrolled diabetes, they have a very high risk of congenital, like fetal malformations affecting the baby in a negative way. So it's very important to quickly bring their blood sugars down. So screening method, like initially, they don't need to fast. They are given a glucose drink, which usually has 50 grams of sugar. They check blood sugar in a lab like 1 hour later. If the blood sugar is above 130, then chances that 90% of you can identify more than 90% of the women with that criteria of blood sugar over 130. If it's below 130, you're well, good to go. Now, if somebody fails the 1 hour glucose tolerance test, then to confirm the diagnosis, we do a 3 hour glucose tolerance test. So in that, the patient has to come to the lab fasting, blood is drawn before, then they're given a drink which has 100 grams of sugar, and then they check blood sugars at 1 hour, 2 hours, and 3 hours. So it's a 3 hour stay at the lab. And during that time, then they check the blood sugar. Blood sugar is drawn, and then there are criteria where they meet that criteria. Then they have a formal diagnosis of gestational diabetes. Next slide. So why we worry about gestational diabetes? What happens? So usually in females with gestational diabetes, pregnant females, they have a more higher risk of blood pressure problems, which is called preeclampsia during the pregnancy. If someone is diagnosed before 8 weeks and the A1C is high, more than 7, they have increased risk of congenital fetal malformation, as explained earlier. So that can result in they can have cardiac defects, heart defects, brain development is affected, and then in the gastrointestinal tract and in the kidneys, the ureter defects. So these are all congenital defects which can happen in patients who become pregnant with uncontrolled diabetes. So again, we always recommend in patients with pre-existing diabetes to bring their A1C below 6.5 before they plan for pregnancy. But typically with gestational diabetes, if somebody develops typical gestational diabetes, it happens later part of the pregnancy. So during that time, the fetal baby organs are already developed. So we do not typically see these congenital malformation in a female with gestational diabetes. Now, other problems can be because of the increased blood sugars. There is increased insulin secretion by the baby. Insulin is a growth factor, so the baby is born with a bigger weight, can't be delivered by normal vaginal delivery, so they need a C-section. Sometimes there can be pelvic trauma when somebody tries to have a normal vaginal delivery. They can be premature delivery because of large size baby. And then when the baby is separated from the mother, the blood sugars can drop, because initially when the blood sugars are high, the baby is also exposed to high blood sugar. So while within mom's abdomen in the uterus, the baby can make more insulin to bring the blood sugars down. And once the cord is cut, the supply of the glucose is no longer there. High insulin levels in the baby blood can drop their blood sugar. So those babies have to be maintained on intravenous glucose after delivery until their insulin levels comes down, and then they start feeding of their own. When they are bottle feeding or breastfeeding, then the blood sugars, they stabilize. So this is important. Then in addition to that, the baby can be born with a increased red blood cell count, maybe more prone to develop some jaundice, high bilirubin, low calcium. Because of the trauma and the difficult delivery, they can be respiratory distress. So these are things which can happen in the baby. Then it's not at that time, but in the long term, women with gestational diabetes, there's a risk of developing type 2 diabetes in the future. So 15% of gestational diabetic will remain with glucose intolerance or diabetic after delivery. And 50 to 60% of GDM females will ultimately develop diabetes over the next 5 to 10 years period. So the problem doesn't end over there. Okay, patient develop gestational diabetes, and that's the end of the story. No, they are at much higher risk for developing diabetes. Then along with diabetes comes, most of them, they are obese, overweight. So comes the problem with blood pressure, metabolic syndrome, heart disease. So it can be a problem down the line. So you just don't wash hands and say, okay, that's the end of the story. You don't need to be followed. They need to be followed lifelong because of the increased risk of developing diabetes. And then in addition, the baby is also, because of the insulin resistant state, they also in the long run are at risk for developing metabolic syndrome and diabetes down the line. So what's the reason why there is people develop gestational diabetes? So it's as explained earlier, there's an insulin resistant state. And on top of that, there is lack of appropriate insulin secretion. So in general, people who are obese, they are insulin resistant, that the insulin doesn't work the right way. Insulin is there, but it's not binding to the receptors to do the right thing, what insulin is supposed to do. But that person won't develop diabetes or gestational diabetes as long as the pancreas can make sufficient amount of insulin. But once the pancreas fails, is not making appropriate insulin, then the blood sugar starts going high. Then during the pregnancy, there are some placental hormones made by the placenta, which also causes more insulin resistance. Then obviously weight gain, as mother is gaining more weight, especially second and third trimester, they become more insulin resistant. And that's the reason why mostly gestational diabetes is seen in the late part of second and third trimester. Next slide. So how we can prevent? So if somebody has risk factor that they can make them more prone for developing gestational diabetes, how we can prevent the onset of gestational diabetes? So before pregnancy, try to maintain an ideal good body weight. If they are overweight, obese, make efforts to lose weight so you have a better weight to start with, then there's less risk of developing gestational diabetes. Do regular exercise, make your lifestyle changes. If your insurance covers, good idea at this time to see a dietitian, attend nutrition classes, so you're on a well-balanced, low-calorie diet and helps you to lose weight so you can prepare yourself for the pregnancy. Then during the pregnancy, average weight gain is anywhere from 25 to 35 pounds. But if somebody's already overweight to start with, then maybe try to gain 15 to 25 pounds, not too much. And if somebody's underweight, they can gain weight up to 30 to 40 pounds. So again, if some females gain too much weight during pregnancy, that is going to worsen their insulin resistance and increase their risk of developing gestational diabetes. Next slide. So now if somebody does develop gestational diabetes, how do we treat them? So once they are screened, 1 hour, they fail, 3 hour, they fail, they have a diagnosis of gestational diabetes. So those individuals usually they're best, if they haven't seen attended nutrition classes in the past, then they should see someone. They should eat well-balanced, low carbohydrate diet. It's important that some people start cutting back on the carbs altogether to keep their blood sugars in a better range. But again, that becomes more like a ketogenic diet, and the ketones are not considered that good. So during the pregnancies, so some patients where we think maybe they're cutting too much carbs, we usually tell them to check their urine ketones. If they're consistently high, that means they need to add some carbs in their meals. Should do any regular exercise. As long as there's no complication with the pregnancy, they can talk with their OBGYN and do regular exercise, usually aerobic exercises. I mean, any walking, cycling, whatever they can handle. And that's good to lower the blood sugars. The weightlifting exercises can increase the blood sugars to some extent, but usually combination of exercises as tolerated, that's the best regimen. Then they are asked to check their blood sugars. They always check their blood sugars before breakfast and then 1 hour after each meal. The 1 hour blood sugar after meals has been shown to have tight correlation with the size of the baby and other fetal complications. So that's why we usually look at 1 hour. So at this time, the current recommendation is that with diet and exercise, they should try to maintain their fasting blood sugar below 95. So we usually give them a glucose meter, test strips, start checking their blood sugars before breakfast, then 1 hour after each meal. So the time starts at the time when they start taking the first bite. Usually we allow 20 minutes to finish their meal. So 1 hour from the start of the meal, they will check their blood sugar. So post-meal blood sugar should be below 140s. If they're checking 1 hour, sometimes if they check at 2 hours, then it should be below 120. So if someone can maintain their blood sugar at these target goals by diet and exercise, then we continue to follow them. No further intervention needed. In between, we will check their A1C, or more commonly, we check fructosamine level. That gives us an idea about the average blood sugar readings over last like a 2 weeks period. So we periodically check those numbers. Then if the blood sugars are not able, if the blood sugars are not able to be maintained at these target goals, then we have to introduce medication. Insulin is most commonly used because it does not cross the placenta. So it affects only mother's blood sugar. So different type of insulins are used, fast acting or long acting insulin based on how high are the blood sugars and what time of the day. Then metformin is also used during the pregnancy. It has been used in patients with polycystic ovary syndrome. So they will continue the metformin during the pregnancy, and that also helps with the blood sugars. It's a relatively, not FDA approved, but still safer drugs has been studied in females who used metformin throughout their pregnancy. Then one may also use glyburide. There have been some studies done with glyburide. This is a medication which helps to increase the insulin secretion. They will give at bedtime to lower the fasting blood sugars. But again, it comes to risk of low blood sugar. It does cross the placenta. It causes insulin secretion, increased insulin secretion in the baby too. So more risk for low blood sugars after delivery in the baby. So again, not that commonly used, but you may come across some, like the physician you are dealing with, some physicians may recommend using glyburide depending upon their practice habits. So once the baby is delivered, most of the time, majority of patients with gestational diabetes, the blood sugar returns back to normal. It's a very quick thing. You'll be surprised, like suddenly blood sugars are back to normal. So that's why it tells also the placenta plays an important role. Once the placenta is out. Suddenly the blood sugars, they are much better. Patient doesn't need that insulin requirement, comes down. So they have to keep a watch. We usually in the hospital check blood sugars for 24 hours. They are good to go. We stop checking the blood sugars. So they can monitor their blood sugars once in a while after discharge. Once in a while, they check blood sugars after meals just to make sure that they don't have to check 1 hour. They can check 2 hours after meal, and at that time keeps below 140s. And if they're fairly in a good range, then we tell them to stop checking their blood sugars. 6 weeks after delivery, they will be seen in the office. We look at the blood sugars if they're checking randomly, do a fructosamine level that gives us an idea about the blood sugars over the last 2 weeks period. Some physicians may order a 2-hour glucose tolerance test. So this is just to look at the overall glycemic control at that time. Then encourage breastfeeding. That's good for the baby too. So it's having gestational diabetes doesn't tell you, oh, you can't breastfeed. Breastfeeding is always good. Stay active, try to lose weight more aggressively once the person has stopped breastfeeding. So that's the best way of lowering the blood sugars back to the pre-pregnancy. Then, as I explained earlier, long-term surveillance is needed because 50 to 60% of patients with gestational diabetes are at risk for developing type 2 diabetes over the next 5 to 10 years. So these patients should not be written off. They are the future. If they don't take care of themselves, they continue to gain weight, have bad eating habits, they will be the future patients who will develop type 2 diabetes. And in some individuals, they can develop type 1 also immediately after delivery, that the blood sugars doesn't go down and they actually diagnose with type 1. But most common, it's type 2 diabetes. All right, I think that was the last slide. So thank you very much.
Thank you. All right, so we're ready to jump into the nutrition portion unless we have questions.
Yeah, so I was just saying thank you, Dr. Hundal. So I was on mute. So we'll start with Caroline's slides.
Awesome. So nutrition for gestational diabetes. Eating a balanced diet is important for any part of pregnancy, whether you have gestational diabetes or not. The food helps your baby grow. It also helps development. So diet is important regardless, but we want to make sure that we eat properly to maintain average glucose levels. So eating properly, like Dr. Hundal said, can help you avoid needing medication if we can control the blood sugars. So individual diets for nutrition with gestational diabetes can be based off a couple of things. So blood glucose ranges, how high is your blood glucose going? Weight, so what weight are you starting at pre-pregnancy and during pregnancy? Trimester and growth rate of your baby. So is your baby growing at the rate that it should? And then physical activity levels. So obviously those who are more active and have a higher physical activity range will need more calories, will need more carbohydrates to sustain energy. So it's dependent on the person. I always like to note that there's always that phrase, eating for two. It doesn't necessarily mean eat twice as many calories, but you just need an extra about 300 calories. And most people don't need that until the second and third trimester, most likely towards the third trimester. So it's a good to note that just because you might think you need extra food, right, you don't need the extra calories until later on in pregnancy. It's also noted that the main goals of medical nutrition therapy for gestational diabetes is to meet maternal and fetal nutrition needs, as well as to maintain that optimal glycemic control. So what are some generalized recommendations? The best way to start off eating is eating a variety of healthy foods. So learning how to read your food labels and making consistent food choices throughout your pregnancy. Especially during diabetes, we don't want to fully eliminate carbohydrates, but other food groups, because we need to have certain nutrients in order to promote good fetal development as well. So in general, your diet should maintain a moderate fat amount of protein, provide controlled levels of carbohydrate throughout the pregnancy, including fruits, vegetables, complex carbs, such as whole grains. So the average we usually recommend is about 2 to 3 meals per day with 1 to 2 snacks, spreading them out in small amounts so that we're not overloading on carbohydrates at one time. Avoid skipping those meal times. We want consistent blood sugar levels. We don't want dropping, we don't want spiking, so consistent meal times. And breakfast matters. So blood sugar can actually be pretty difficult to control in the mornings because of normal fluctuations in hormone levels. So eating refined cereals, fruit, milk might spike your blood sugar in the morning. So it's important to find a good balance of some things that we'll talk about in a minute: protein mixed with carb with some fat for good sustainable energy levels. So the big topic of carbohydrates. So like I said, spreading out through the entire day. Usually we say about less than 50% of calories consumed per day should be from your carbohydrates. Of course, that could be a little less depending on physical activity level, personal diet plan as well. But we want those consistent carbohydrates spread out and with a variety of whole grains. So focusing on high fiber foods, making at least the general recommendation is about half of your grains, whole grains. So those whole grains contain fiber, which will slow down the digestion of your carb, which will help your glycemic index. It goes down with the high fiber foods. So going things like grains, beans, taking note of the starchy vegetables that do count towards your carbohydrate amount. Usually we recommend about 6 or more servings per day. One serving might look like 1 piece of bread, or maybe 1 ounce of ready-to-eat cereal, half a cup of rice or pasta. Of course, this is individualized based on patient care. So if you're struggling with high blood sugars, we would consult together and kind of change the amount of carbohydrate that you would have at one time based on what your blood sugars are doing. So our next one is vegetables and fruits. Obviously, we want a good variety. They have tons of vitamins and minerals. 3 to 5 servings per day for vegetables, fresh, frozen, canned. A tidbit we always recommend is rinsing your canned vegetables as well, just to get the extra sodium off. But going into fruits, we want to make sure we have maybe about 2 to 4 servings per day. But the key component with fruits is the serving size. We want to make sure that the serving size is not a whole bowl of watermelon or an entire, string of grapes. We want to have small portion sizes. A lot of the time with patients when we review fruits, we talk about the serving size of sugar per 100 grams of fruit or half a cup of fruit. And we kind of go through, just because of the serving size, like bananas, citrus, grapes usually have the highest concentration of sugar. We talk about ways to include them in small amounts and pair that protein with it. We'll talk about protein in a minute, but we want to make sure that we balance out our fruits in our entire day of eating. Also like to touch on fruit juice. We want to absolutely try to limit that as much as we can, because you're taking out the entirety of the fiber that was in that fruit that was helping to slow down digestion. The fruit juice is quick sugar, so it's going to raise your blood sugars. So trying to find different beverage substitutes instead of using fruit. And that covers our fruit. But probably one of the biggest questions I always get is, how can I eat desserts and sweets? Because you got pregnancy cravings, you want chocolate, you want different types of things. And there is a way to include them in a safe way. Obviously, we don't want to go overboard, but we work on ways to include those into a regular healthy diet, not in excess. So monitoring your portion sizes. Talk about ways to share with others or split desserts, things like that, things to pair your desserts with which we'll get into in a moment. And frequency. Obviously, ice cream every night will cause high blood sugar, most likely. But pairing out different things, seeing if you can switch up your different items, including more whole grains or protein in your meals to help slow down that digestion of those desserts and sweets. Limiting sugar sweetened beverages as well. So sodas, fruit juices, sugar iced teas, right? Trying to find different substitutes for your beverages, because a lot of the time there's a lot of sugar thrown into those. And then keeping an eye on your sugar-free products. You might think, hey, good for diabetes to get sugar-free items, but take a closer look at your product. When it says sugar-free, some of those sugar-free items have a good amount of carbohydrates in them. For example, I was just talking to someone the other day who had sugar-free ice cream, but she's like, my blood sugar continues to go up after the sugar-free ice cream. That sugar-free ice cream still has a good amount of carbohydrate in it. So sugar-free doesn't always mean carbohydrate-free. So the key here is just to make sure you read your nutrition label. As you can see right here on the screen, if you compare two different foods, one is sugar-free and has a lower carb density, that might be a better option for you to choose. So it's all about trying to find the best, most balanced option for yourself. And so I always say, look at the grams of carbohydrate, don't just look at the sugar content as well. And then our next item of business is protein and fats. So something I think is primarily really important to include in a regular balanced diet, protein especially, because protein is going to balance your carbs out. So we talk about ways not to eat a carb by itself because that carb is going to be digested fairly quickly. So when you pair it with a protein, you're going to slow down digestion because that protein is pretty complex. So for instance, like if you were to have just bread, your blood sugar would pretty much spike up. But if you were to pair turkey or maybe a piece of ham or add some cheese to that piece of bread, you would slow down the digestion, which means your blood sugar wouldn't jump as quickly. So proteins could consist of meat, fish, dry beans, eggs, and nuts. Also on the side, on the right side, there is some plant-based. I get a lot of questions about different plant-based sources if some people can't tolerate the meat products. Obviously limiting our red meat to 1 to 2 times per week, searching for a leaner cut of meat to decrease the fat content. And then making sure we portion size the meat. So I usually use that my plate method that we've discussed many times here before, where you've got a really great portion of vegetables on the half of the plate. You've got a fourth of the plate that is about less than fourth of the plate is carbohydrate. And then your second largest portion would be your protein. And that would help balance out and give you a good balance during your meal to hopefully support good blood sugar levels. Fat would also be an important component to include in your meals. I think on the very first slide we had today, there was a picture of a breakfast. It had toast, eggs, and avocado. The fat helps to slow down digestion as well. So when we pair fat, carb, and protein, we not only have good blood sugar control, but we have good satiety overall. So it means you might stay fuller longer, which means you might not need as many snacks, which means you might not get hungry and start picking around. So keeping yourself full and satisfied is also an important part. Important fats to include might include avocados, fish, nuts, oils. Those omega-3 fatty acids are fantastic. And then limiting those saturated fats, which would be red meat, cheese, butter, those types of things. And then our other lifestyle changes, just monitoring your blood sugar and tracking your carbohydrate intake. So if sugars are pretty all over the place, your doctor or dietitian might ask to track your intake just to keep a food log to see, how many carbs are you intaking during a day, including a safe exercise plan. So like Dr. Hundal expressed, consulting your physician on what would be best for you. And then continuing to follow up with your dietitian post-delivery, because we can create lifelong habits and healthy things to practice dietary and exercise-wise that would help maintain stable blood sugars over long term. But I always like to stress that diet recommendations are personalized and addressed by a case-by-case basis, because each person, especially with gestational diabetes and pregnancy, are entirely different. So these are just general guidelines on kind of what to focus on, but you can really dig deeper into blood sugar control and nourishing yourself and baby correctly when you get into individualized care. And that's it.
All right. Well, thank you, Caroline. So I think what while I was listening to you guys, one of the things that what's most important with this one, it seems like the prevention, and can we actually do something prior to this becomes a problem? And Dr. Hundal, from your slides, I heard patients with obesity or morbid obesity, they may be likely to have this problem at the beginning of their pregnancy. They should be definitely tested right away, right? And the other thing that I heard is if there's an immediate family member who has diabetes, those people are at more risk. So those kind of like, I think those are the issues that we always find with these types of problems anyway. So do we want the patients to be tested right away if they have these one of these issues that we just said, or do we need to wait until if they have any symptoms?
No, it's just, again, as I explained earlier, people don't get any symptoms, majority of them. So until unless somebody has totally undiagnosed and uncontrolled diabetes, type 2 diabetes. So if they have those risk factors as per guidelines, they should be tested earlier. They can be tested even in the first trimester of the pregnancy. And if they pass the test, then keep a watch. Then periodically, the OBGYN usually test them again later on, so that you don't have to wait for 24 to 28 weeks to test them.
Sure. Well, I was 11 pounds when my mom had me, so that's probably why it's diabetes.
Yeah, so definitely that puts you at also risk. Obviously, your mom needs to be monitored, and then it puts you at higher risk. So again, that's why you do a lot of exercise, so that you have minimized your risk of developing diabetes. So that's a good thing.
That's true. That's true. All right. Well, do you guys have any questions? Donna is quiet, so I'm assuming she's okay. So we are good.
Sorry, I was trying to get myself off mute, but I didn't have any question. But I thought that was a great presentation. I just wanted to say to Dr. Hundal and Caroline, thank you. I know for a couple of years we've received a lot of questions about this topic, and so again, I think it's going to help our patients. So just wanted to put that out there.
Well, thank you.
So again, thank you, and we'll be back with the support group on the 4th week of this month, and then we'll have another presentation on the 2nd Wednesday of February. So we'll see you soon. Thank you. Bye-bye.
All right. Thank you. Good night.